Okay, I think we will kick off. My name is Kim Crace. I'm VP Innovation and Senior Scientist at the Canadian Centre on Substance Use and Addiction, and I am also a prof at the University of Ottawa in psychiatry. It's really great to be here with you guys today, and I think we have a pretty incredible panel lined up for really talking a lot about what are some of the challenges, but also the opportunities in substance use health, and what are those impacts related to policies, outcomes, and the wellness, both the people we serve and the community at large. So what we're going to learn about today is we are going to have ourselves kicked off with Anthony, who is going to talk about this concept of what is substance use health, how does this shift our mindset, what does this mean, and how is that maybe going to change some of our approaches to both our practice and our research. And then we're going to have Pam, who's going to talk about the costs and harms study that's related to substance use. After that, we're going to have Bryce talk to us about Canada's guidance on alcohol and health and how that really is looked at through a substance use health lens, and also what that means in terms of how we can help reduce the harms of people across Canada. Then increasingly important thing we hear about is wellness at work and in the workplace. So we are going to hear from Shauna, who's going to talk to us about the connection of physical and mental well-being and substance use in the workplace. And then we are going to wrap it up with Miguel, who's going to talk to us about how the substance use health needs are evolving and how that changes and shifts some of the competencies and skills that we need in our workforce and are able to respond to the people who are looking for care and those who need our help. So with that, I am going to start off by introducing Anthony, and then he is going to come up and share his talk with us. So Anthony Esposti is a visionary leader and CEO of CAPSA, which is an organization with provincial and national reach dedicated to improving the health outcomes of people in need of support for their substance use health. With a team of highly skilled subject matter experts who are informed by their lived and living experience, Anthony leads system-level change by providing tangible solutions to address embedded systemic stigma. So with that, I'm going to turn it on over to Anthony.
Thanks for joining us this afternoon. I'm going to take you through sort of an overview of substance use health to help frame the conversation that we're going to have here this afternoon. You may have heard this term batted about, maybe just new this week. Maybe you've heard it before. But substance use health is an important principle that CAPSA developed over the last couple of years to expand our thought beyond the illness-based model of simply addictions. And I'll get into that a little bit later. But who CAPSA is, just to start off, we are an organization of researchers, policy analysts, and educators that hold the dual expertise of lived and living experience. So this is the lens through which we look at all our work and approach all systems of care in hoping to affect positive change. So why are we talking about this today? Most people in Canada use substances. That's just a fact writ large. Some 72% of us over the age of 15 use substances, including alcohol and tobacco. Only 4.4% of the population have a substance use disorder. Yet all of our research, our systems of care, all of our resources are focused on that 4.5%. Where in the system is there evidence-based research and information and knowledge products and resources for people to address their health with respect to their substance use? So like I said, substance use health is a shift away from that illness-focused. Just like in mental health, when we once focused strictly on mental illness, there was very little attention paid. People were heavily institutionalized and very little focus paid to mental illness. But when we began speaking of mental health, all of a sudden, more conversations were being had, more services, more resources were available to people to address their mental health. And that had an overflow effect for people with mental illness as well, in improving the standards of care for people with mental illness. And so you'll also see that the stigma for mental illness and for mental health started to fall away. We have campaigns now. Here in Canada, we have Bell Let's Talk, where people are encouraged to talk about their mental health and how they may have overcome and receive support for their mental health. People in the workplace will talk about their anxiety or how maybe they're managing their depression, or even at a very base level, the stress that they're under. Substance use is still highly stigmatized. People don't talk about their substance use. They don't talk about it with their families, let alone talk about it in the workplace. And it's because of this focus on illness and this thing that nobody wants, a substance use disorder. Nobody wants a substance use disorder, so no one talks about it. We believe that that has created this, not only a systemic stigma that has been the result of the social stigma attached to substance use, but a great deal of an internalized stigma for people as well. So we believe that substance use health will support the health of a wider population. It enables a public health approach to people who use substances. And in fact, it also will provide systems of support for people who don't use substances. I'll show you a spectrum in a moment that includes something that you may not have seen before. It's also the availability, the equitable availability of information and supports for people to address their health around their substance use. So we're looking to expand this conversation beyond the realm of addictions. And I know I'm speaking to an audience that's very focused on substance use disorder and addictions, but I think there's a room for the conversation to talk about health with respect to people's substance use. So I talk about a spectrum. The spectrum of substance use health, this is a spectrum that CAPSA developed. It spans from, let me just see if this is going to work. Excellent, we have animation. It spans from no use to lower risk and higher risk use, to where people experience a decline in their health, to a substance use disorder. So that's the full spectrum. And so CAPSA is the first organization to actually include no use. And that's important because there are people who have never used substances. There are people who have stopped using substances. And where are the supports, where's the information for people to continue to hold that decision to not use substances if they choose? So it's important to include that in this discussion. What's also important to understand is that the spectrum is very focused on people's relationship with substances. It's not just how much you use or what you use, it's about how I relate to substances. And so we talk about people that no longer or have never used, people that may use one or more substances, and that could be in a lower or higher risk way. And then when you start noticing that change in your health, this is still outside of a disorder, but you're starting to recognize that change in your health, a very critical point in the healthcare system, where people can recognize the change in their health and a need to address it and the need to have that readily accessible system of care. To the point, of course, what this crowd knows a lot about is the substance use disorder. The other very important thing about this spectrum is that a person can experience stigma regardless of where you fall along the spectrum. And how does that manifest itself? Well, in no use. You ever been in a party and asked someone, why aren't you drinking? Have you ever heard someone say, I've heard some of my friends say, I don't trust anyone who doesn't drink. So there's that question, especially around the quote unquote socially acceptable forms of substance use. And then when you look at the lower and higher risk, yes, so there are socially acceptable forms of substance use, but what if you use illegal drugs? What if you use substances via injection? So it's the mode of use, the type of substance, you can experience stigma even though you don't have a disorder. And then, of course, substance use disorder. People with substance use disorder are the most highly stigmatized of any population in Canada. It's a highly stigmatizing condition that people just don't talk about. So some of the core principles of this spectrum is that everyone has a place on it. Everyone in this room can find themselves on this spectrum. Everyone deserves equitable access to care with respect to their substance use health, regardless of where you land on this spectrum. and that health promotion can occur at any point. We don't have to wait until people are sick. Health promotion can occur at any point along this spectrum. And we also want to recognize that substances are often used in ceremonial and medicinal purposes. So we can't ignore some of the benefits of substance use. While all substance use involves risk, there are still also benefits. So we recognize benefits of substance use as well. How am I doing for time? Okay. So health encompasses everything. A substance use health model starts with equity, equitable access to care, regardless of in CAPSA, we frame it as all people, all pathways, regardless of who you are, what you use, how much you use, and regardless of what pathway you choose to wellness, there needs to be an equitable system of care. And with that, it's supported by education, providing people with evidence-informed information so they can make informed decisions of their substance use. Recognizing that most people will use substances, where's the information that we can get to inform our substance use? You pick up a can of water, this is the example I use all the time. You pick up a can of water, and there's a label on that can that tells you every ingredient in that can of water, including how much protein and how much carbohydrates are in a plain can of water. You pick up a bottle of wine, it tells you there's between 12 and 18% alcohol in it, and that's it. What are the other ingredients? And don't I want to know? So we need that sort of informed education. The supports for increased health. So we're talking about that access to that broad spectrum of care on a step care model. Not everyone needs the full weight of the substance use disorder medical system. We can use a step care model in addressing substance use health. And then supported regulations. We need regulations on how old you need to be in order to buy tobacco. How old do you need to be in order to buy cannabis, alcohol, those sorts of regulations to help support the health of the population. We did a national survey. We asked 4,000 people some questions, and this isn't people with substance use disorder. This wasn't people who just use substances. This is everyone in Canada, pulled out of everyone in Canada. 78% of those people believe that substance use health is an urgent issue. Amazing when you take out the word addiction, how people can get behind something called health. 78% of the people believe that health is an urgent issue, and that 80% of people need more access to care around their substance use health across the spectrum. The curious thing is that 79% of the people don't think they have any reason to talk to their healthcare provider about their substance use. So you see what's happening here. People are saying those people need access to care and they need information. This is an urgent issue for those people, but not me. And that's what the focus on illness has done, is that as long as I don't have a substance use disorder, my substance use is healthy. Imagine if we expanded that conversation, just how much healthier we'd be. So the need for a health promotion approach to substance use could not be clearer. We need to shift away from that illness-based model. We need to be talking about our health and have equitable access to address our health around our substance use here in Canada. Thank you.
So I've been fortunate enough to see Anthony and Sean and Brianne and others who have presented this model. And every time I learn something completely new and a new way to frame it to the people we take care of. So I think there will be lots of questions at the end that we have. But before we do that, we're going to turn things over to Dr. Pam Kent. And Pam is going to talk to us about the costs and harms of substance use in Canada across the spectrum of use. So again, these aren't just related to people who have substance use disorders, but overall in Canada. So you can kind of see our theme of how substance use affects us all. Dr. Pam Kent is the Director of Research and Emerging Trends at the Canadian Centre on Substance Use and Addiction. She oversees a suite of initiatives aimed at collecting unique and timely data with the goal of providing a comprehensive picture of alcohol and the alcohol and drug situation here in Canada. She's also the co-chair of the Canadian Substance Use Costs and Harms Working Group and co-author of the associated report, which estimates the societal costs of substance use in Canada. So when you see at every presentation, what is it, 53? 49, thank you. The $49 billion cost related to substance use in Canada, we see that over and over again. That'd be Pam and her group. Over to you, Pam.
All right, thank you.
Thank you very much. Okay, so I'm going to talk to you about the costs and harms of substance use in Canada across the spectrum of use. This is a joint initiative between Canadian Centre on Substance Use and Addiction and the Canadian Institute for Substance Use Research. So just want to acknowledge that I have no conflicts of interest and that this work is funded by Health Canada. Okay, so a little bit of background here. Really, so Canadian substance use costs and harms, we affectionately refer to it as CSUCH. Prior to kind of the modern work, the most recent estimate or analysis or economic analysis of costs and harms in Canada was a initiative, a study released in 2006 with 2002 data. So you can see kind of the changes over time in the last 2 decades in the substance use field. Just so many changes. We've seen the uptick in prescription opioid use, strong public health messaging with related to tobacco use, COVID-19 pandemic, legalization of cannabis. So obviously the need for more recent data was obvious. So we started this work in earnest in about 2016. We've had 3 iterations thus far. The most recent was published in summer 2023. It had data from 2007 to 2020, and we are currently working on an update to 2023. So I'll just give a little bit of background here. The study encompasses 8 substance categories that are listed on this slide. So we have alcohol, tobacco, cannabis, opioids, then cocaine, other CNS depressants and stimulants, and then an other category. We also have 4 major cost categories, and I'll get into this. I have other slides that break this out in more detail. So fundamental to the project, to the methodology, is what's called the attributable fraction methodology. And really this, again, it speaks to what's included in CSUCH across that spectrum of use. So we include conditions and events that are fully attributable to substance use, like drug poisonings or drug-related crime, but the study also includes partially attributable conditions. So various cancers related to alcohol or violent crime as examples. So using this methodology, you really can't make out this table at all. It is just a snippet from our report. There's 92 health conditions that are included in the project. So these include both kind of those fully and partially attributable conditions to substance use. And this is based on, you know, WHO, its status on alcohol and health, economic burden of disease for illicit drugs, U.S. Surgeon General report on tobacco use. So really top quality evidence is what has arrived at these health conditions. So I've got a few slides here that kind of go over the methodology. I'm really going to just skim over this. It's, again, you cannot read it, and it's all to say that there's a lot of data. We have 20 indicators within the CSUCH project, and just the vast number of data sources that are included to derive these estimates. One of the fundamental building blocks is the prevalence of substance use. So we have this across years, across provinces and territories, broken out by sex, and 4 major age groups. This is using the national survey data, as well as a lot of auxiliary data sets. Healthcare costs, you can see the categories here. We have 8 categories, so a lot of hospitalizations attributable to substance use, physician costs, specialized treatment. Again, a lot of data is going into this, mainly from Canadian Institute for Health Research, so a lot of the hospitalization data and other sources. Lost productivity. So here we include both long short-term disability and premature mortality, and just productivity lost as a result of premature mortality. Data sets, vital statistics database for the mortality, and then labor force survey, even CPP disability payments for both short and long-term disability. Criminal justice, 3 categories here: policing, courts, and corrections. Using Statistics Canada, their criminal justice data sets, mainly for these categories. And then finally, heterogeneous group, other direct costs, anything that didn't fit nicely into the other 3 categories. You can see it's just a mix of different cost categories here: research and prevention, fire damage, as examples. And again, just a heterogeneous set of data that goes into this. I'm going to go over just some of the key findings. Kim mentioned total cost of substance use. So in 2020, that total cost was just over $49 billion. You can see the breakout across the categories here. So over 46% of the costs are attributable to lost productivity. And then that's followed by healthcare and then criminal justice after that. If we look at the breakout per person costs for the provinces and territories, it's just under averaging about $1,300 per person in Canada. You can see the costs in the territories are considerably higher than the other provinces. And that's really because prevalence of substance use is higher in the territories, as well as costs for services. When you look at the breakout across the substances, this is always an interesting slide for people, because you're seeing here that really it's 2 of our legally available substances. It's alcohol and tobacco that are accounting for the greatest proportion of costs. So 63% is with alcohol and tobacco. If we were to throw cannabis in there, it's roughly about 70%. And then 3rd highest is opioids. And so that's not to kind of diminish the impact of opioid drug crisis, but just it shows really just, again, the impact of our legally available substances. Oh. Okay, this slide shows us over time. So from 2007 to 2020, just the trends across the substance categories. And it's really interesting. You're seeing alcohol, just a really kind of insidious increase over those years. It goes 21% from 2007 to 2020. We're seeing, though, tobacco, actually a decrease, a similar decrease in costs over time. The other substances, just again, they're the lower costs. There's actually quite a significant increase, though. When we look at opioids, this data, again, is only to 2020, and we know certainly the situation with opioids deteriorated post-2020. So you are seeing a blip. Costs actually did increase, I think, 66% for opioids, and that's only going to increase in recent years. In fact, this is a breakout, actually, of the oh, sorry, no, that's, excuse me. I'll go back to, sorry about that. And you can't really break out cannabis. Everybody asks about cannabis. There's actually about a 7% decrease in costs at 2020, so the post-legalization. And really that's attributable to a decrease in criminal justice costs. I'm going to just go to this slide here. This is the slide with the overall deaths attributable to substance use, and it might surprise you actually to see tobacco and alcohol, again, are the highest. So combined, they represent about 85% of substance attributable deaths. Opioids is about 10%. But you can look at the data different ways. And here, now we're looking at the potential years of productive life lost. So this incorporates when a person died within their lifespan. And so for tobacco, we know that tobacco-related deaths, chronic illness, so people die at a later age. Alcohol, a little bit younger, but then opioids, it's substantially younger. So this is why we're seeing opioids at the top here, because there's just so many years of productive life lost because people are dying from opioid poisonings at a young age. I'm just going to switch gears for a moment to talk about the crime section, because it's actually really interesting as well in terms of the methodology and the findings. So just like for the health conditions, we have a set of attributable fractions which show that relationship between substance use and health conditions. We also have a set of attributable fractions showing the relationship between crime and substance use. These attributable fractions were developed using a really rich data set from actually an intake survey for offenders who are entering the federal correctional system and looking at their need for substance use services. The survey, over 30,000 offenders have filled in this survey. There's questions about what is that, were you intoxicated at the time of your crime, or were you looking to obtain substance as a result of your crime? It's probably hard to make out on the screen, but what you see here is that close to 50% of substance use, 50% of crimes are related to substance use. Alcohol alone, 26% of violent crime is related to alcohol use. So here is a breakout then of our criminal justice costs. Again, we see alcohol at the top in terms of that link at $4 billion, followed actually by cocaine. Again, there's a strong association between crime and cocaine use. So that just kind of shows you a different profile. And I think it also speaks, again to just across the spectrum of use. We're not talking about, again, just this narrow population with substance use disorder. Anthony quoted statistics showing us that, over 72% of individuals consume substances. And so that is the breakout of the data in the CSAM project. So what does it all mean? Certainly, costs with alcohol are rising. We should really be aware of that. Costs with tobacco are decreasing. Could we apply some of the lessons learned with strong public health messaging for tobacco to alcohol? Certainly in this project, we are seeing increasing costs related to opioids and stimulants. So again, there's a need for services and supports across the spectrum of care. And cannabis, costs with cannabis. Why they've declined slightly after legalization, but this is data to 2020. So I would say we still need a lot more evidence and a lot more data collected to really see the true impact there. Thank you.
That's excellent, and lots of food for thought in terms of helping guide where some of our public health focus needs to be. So now I'm delighted to introduce Bryce, who's going to give us an overview and some learnings on Canada's guidance on alcohol and health and substance use health. So Bryce is a senior knowledge broker at CCSA, and at his time at CCSA, he focuses much of his work on alcohol-focused projects, most recently the mobilization of knowledge related to Canada's guidance on alcohol and health. He holds a degree in psychology and an MA and PhD in human kinetics from the University of Ottawa. So over to you, Bryce.
Thank you very much. Okay. So I wanted to start out a little bit differently. I wanted to ask everyone to picture themselves in their own personal life, so outside of your potentially clinical role, or Kim mentioned maybe another way to think of it would be more in general practice. So you're speaking to someone, there's no indication of high risk alcohol use or alcohol use disorder. But just someone in your life is asking you, they know what you do for a living, and they say, I hear different things about alcohol use. In general, what would you say to me about alcohol? So this is almost your slogan, your 1 to 2 sentences about alcohol. So I'm going to give you a second just to think about that. So, and extra points if you can come up with something that's 3 to 7 words. So just your slogan, short slogan about alcohol. So just, I don't think I need to go too far into this. Pam just went to it in detail. So a lot of costs and harms associated with alcohol use, 40% of the overall costs and harms. Alcohol is very prevalent in terms of the use. So 24% of the population in any given year hasn't used alcohol at all. 28%, excuse me, have had 1 to 2 standard drinks in the last week. 14% have had 3 to 6 standard drinks in the past week. And 34% have had 7 or more standard drinks in the past week. So again, very prevalent. Coming back to that question though, so maybe, I see some people writing, so maybe you wrote down your slogan, your alcohol slogan. So I would say, so I'll bring you to the challenge of updating the guidance on alcohol and health from the old low-risk alcohol drinking guidelines to these new ones released in January 2023, is what can you say to people that's useful about alcohol in a sentence or two? So this is our overall recommendation. So everything I say follows from this overall recommendation. If you had to say it in 3 words, you could just say, consider drinking less. So this is, again, just a general framing of a conversation about alcohol, and one that I think lends itself to a substance use health spectrum, and I'll get into that. Another three-word way of saying the same thing, less is better. I'll read the title of this. So less is better is the best message when talking to patients about alcohol. So this was from a spring 2023 Canadian Medical Association Journal editorial. Again, so it's a good way to frame up a conversation about alcohol. Even before the guidance was released, this is from Canada's Food Guide, you have to click on 3 links down to get to this key message, but there are health risks linked to drinking alcohol. You could do a lot worse than say, in general, this is a general way to think about alcohol. So one thing maybe I would highlight, so there was a lot made in the media after the low-risk alcohol drinking guidelines were updated. Again, they were released in 2023. If you asked a lot of people what we said, you might get a line that, well, they said 2 drinks a week. They set a new line in the sand. If you're under that, you're doing great. If you're over that, there's a problem. That wasn't what we said. We highlighted a number of different risk zones, so you can see them here, including 0, so another first. So in the substance use health spectrum, there was no risk that was included. 0 was actually included on this risk zone spectrum for weekly use. So 0 drinks at no risk, 1 to 2 drinks per week at low risk, 3 to 6 at moderate risk, and then 7+ for increasingly high risk. So we think that this does lend itself to a discussion from a substance use health perspective. I think Anthony covered it well, so we know a lot of people in this room are thinking about high-risk use or alcohol use disorder if you touch on alcohol in your work. But what we would say is that this really does talk about no use, lower risk use, and higher risk use. And Anthony gave a few great examples in terms of the potential for stigma for non-use. I think with alcohol, it's probably uniquely high. But even if we take our overall key message, consider drinking less seriously, for a lot of people in their own lives, they might feel stigma for trying to make a change. So even on occasion by occasion, if you're not drinking and you're with a group you usually drink with, you might feel stigma in that situation. I did want to highlight that, oh, sorry, go back, if it lets me. Okay. I did want to highlight that in a warm-up discussion for this, Anthony actually mentioned that CAPS's survey where they're asking people about substance use. they actually had to specify alcohol. We're asking you about substance use, including alcohol, and you'll often see that in a lot of breakdowns of substance use. So substance use, including alcohol, alcohol and drugs. So part of this conversation around alcohol and alcohol use and alcohol health is challenged just to help people think about alcohol as simply one of the depressants. You can't see it very well on the screen, but again, it's just among the depressants. And the effects of alcohol are like other depressants. Maybe a little bit of an aside, but if you're not used to the concept of a standard drink, so all of the drinks in front of you have 13.5 grams of alcohol. A bit of an aside, every one of those drinks would have 90 calories from ethanol. So that is potentially a somewhat unique aspect of alcohol. Another potentially, it jumps out at me, I guess, is the mammoth amount of ethanol we need to use for an effect, or the mammoth amount that people would use on one occasion. So 13 grams to begin with. 60 is sometimes a cutoff for binge drinking, or more. So again, just an aside. I would say that from the low-risk alcohol drinking guidelines to this guideline, this was updated. Guidance around per occasion use, so 2 for males and females, was highlighted as where risks begin. As opposed to, this group might be really familiar with binge drinking, so 4 for females or 5 or more for males on any occasion. This opens up a discussion, I think, about where you start to see some harms. Whether those harms they're more short-term harms, injuries, violence, that kind of thing. Another key message is just around reproductive health. This is the same from at least 2012 with the low-risk alcohol drinking guidelines. If someone is pregnant or planning to be pregnant, 0 is the safest. If someone is breastfeeding or chest feeding, 0 is safest. For youth, this is a new key message just in terms of because of the specific risks for young people and the specific negative outcomes for them in areas that might be important, like their academic performance, the key message is to consider delaying your use as long as possible. For sex, at 7 or more standard drinks per week, the risks take off more steeply for females. And there's a lot more injuries, deaths, and violence from men's drinking. So again, if you are outside of a work setting and talking to a female or a man, you might highlight some of these facts. If in that example of your personal life or outside of work, or even if you knew someone was, for instance, taking care of someone else, or they were on different kinds of medication, they were using machinery, a vehicle, there are many circumstances where the key messages emphasize 0. And again, to loop back to that overall message of considering drinking less, as part of the guidance there is a breakdown of some strategies to maybe help you cut back on one occasion or to set a limit and stick with it. These are pretty common from the low-risk alcohol drinking guidelines as well, so they've been around. Just reiterating that a lot of the key messages, again, I think there was a perception that this was a big shift. A lot of these key messages are the exact same that they have been from the low-risk alcohol drinking guidelines, and they continue to be the same. Because alcohol increases risks across all these areas, less drinking means less harm from alcohol. And the overall thrust of the guidance on alcohol and health is to help people make informed decisions about their own use, to inform a conversation and a general conversation. I'll touch on it in just a moment, but maybe I'll touch on it now. I think it's important to note that when we're thinking about this and that alcohol and the substance use health spectrum, that we really think about no use, lower risk use, and higher risk use in terms of indicators of declining health and indicators of alcohol use disorder. That is not covered in this guidance. I guess I kind of think of it like if we're talking about healthy sleep messages probably don't cover insomnia. So, similar in that regard. So our knowledge mobilization has generally focused on thinking about these key messages, but in actual context. So earlier I was trying to get you to think outside of potentially your work if you're in a clinical setting, but our work is on the guidance on alcohol and health is to help facilitate how do these messages work in your setting, how do they need to be adapted, what would they look like, how could they be used in different settings. So a lot of our partnerships focus on that work. I'll highlight the bold if that comes through. So the Canadian Medical Association, they had that editorial, but they also share this as a policy, the guidance on alcohol and health. In BC, they shared this as part of their high-risk drinking and alcohol use disorder guideline, more specifically as part of patient education, patient conversations in general about alcohol include these kinds of key messages, high-level key messages that make sense for the broad population. Embedded within validated processes for flagging high-risk drinking, flagging declining health, flagging the symptoms of alcohol use disorder. I'd highlight the numbers I've seen are that there are about 3.2% of the population who have an alcohol use disorder at any given time. So this is a self-help resource that we put out. It's based on motivational interviewing, and it's about taking a month to re-examine your relationship with alcohol. And because a lot of people have clinical roles, and I realize there are a lot of barriers to doing something new or having a clinician-led brief intervention, for instance, these kinds of resources could be really relevant for a lot of the population who's just rethinking their drinking. They might be going from more moderate risk to lower risk or within that higher risk zone, just making a change. So there isn't always a need for an intervention that's overseen by a qualified healthcare provider. Of course, it's important and necessary in a lot of settings. This is our communications toolkit. If you're interested in printing, distributing any of the resources that we have, a lot of partners do. They adapt them for use in their settings. We're happy to work with you on that. We do have a campaign that shares the key messages from the guidance. We're happy that a lot of partners have taken it and done different things with it. This is from Prince Albert, Saskatchewan. It's actually their community billboard where they display the campaign. So again, some opportunities even in the community to open up this discussion. We continue to work with national partners around, again, what does it look like to use these kind of messages in your setting? And yeah, I think I covered everything I wanted to mention. So just that this is population level key messages around alcohol. It's about opening up a conversation in general about alcohol. It doesn't cover declining health and substance use disorders. There are best practices there that need to be put into place and work. But this is about that first part of the spectrum, no use, lower risk use, and higher risk use. Thank you very much.
Thanks so much, Bryce. I think there was so much media attention around this. It's really good to see what the gist was intended to be about this type of, and I see a lot of nodding and smiling in the audience, so I'm sure there'll be more questions about that. All right, we're going to, thanks, Sebastian. We're going to turn it over to Shauna now, and she is going to talk to us about challenges and opportunities to addressing substance use health and workplaces. Shauna Meister is the Associate Director of Innovation, Evidence, and Practice with CCSA. She conducts evidence-based research on substance use health and the workplace and alcohol and drug-impaired driving, as well as leads activities in new and diversified areas. Over to you, Shauna.
Thank you, Kim. So, as many of you know, the majority of the adult population works, and the workplace can be a significant factor that affects our substance use health behaviors. So today I'm going to talk about some research that we did and some of the findings from that research on substance use risks and workplace factors. But I thought I'd start off the presentation with a quote from somebody that we interviewed. He's in his 40s, and this is what he told us. Up until my current employer, I've been self-employed in the safety-sensitive sector, and we just didn't have any policies on substance use. Even our clients expected us to treat them with drugs and alcohol. Lots of people we were doing business with, they were like, yeah, we'll sign the purchase order. When is the party going to start? The very first time this happened, it was with two mentors of mine. We just closed the biggest deal I had ever closed, my first six-figure deal. My mentor said, "Congratulations." And out came the party, the treats, the drugs, and the alcohol. In my head, I'm like, these are two guys I admire, two guys that are mentors to me, and this is what success looks to them. The train was on the tracks, and I couldn't stop it. So I'd like to keep his experience in mind as I talk about some of the findings. Before moving on, I would like to acknowledge my colleagues who've supported me on this project, Bryce, Lee, Seema, Balpreet, and Sarah. We have no conflicts of interest to declare. I'll just skip ahead to the study. So why should we look at workplaces? There are a lot of reasons. One of them is that the research is really just starting to emerge in this area, but we're seeing that there's a real need for people to talk about workplace pieces, especially because if this is a place where people are experiencing problems, this is also a place where we should be considering doing prevention and education. We also hear from people that there's not really enough supports for the employers and for the employees. And as an organization ourselves, we do receive a lot of requests from employers for training, for resources, for help. So we know there's a need out there. And one last thing I'd like to leave you with is that a really important reason is that most employers require that their employees read their policies on a regular basis. So this is a really great opportunity to provide sustained ongoing education and prevention about substance use, about stigma, and about how to manage people's substance use issues. So the study, I'll be very brief. We conducted 2 national studies, 30 focus groups. We interviewed 16 people with lived and living experience, so approximately 1,600 participants. We talked to managers and employees separately to get their different perspectives. We did look at safety-sensitive and non-safety-sensitive industries. So for reference, safety-sensitive industries are those where there's potential for harm to the individual, coworkers, the public, or the environment. And these can include airline pilots, medical practitioners, or construction workers. Non-safety-sensitive positions are those where there's minimal risk to the individuals. This could be office workers, department store employees, or software programmers. We also looked at some individual industries more specifically, so we'll have some data on that. So in terms of results, really it's first important to acknowledge that what we heard from people in our city was that most workplaces acknowledged that there was some sort of substance use factor in their workplace. We didn't really come across too many people who said that this wasn't something that they faced in their daily work lives. So in the surveys, we did ask participants if they had consumed a substance during or within 2 hours before work or working impaired, high, or hungover. And there were 2 kind of general observations we had. First of all, that more often, managers were more likely to report using a substance before or during work than employees. And overall, safety-sensitive industries were more often likely to report that substance use, that they use substances than in comparison to non-safety-sensitive industries. To be clear, as we've heard already, substance use, not all substance use is problematic. And so the questions we asked could have reflected anywhere on the spectrum of use, from occasional use right up to substance use disorder. But the key point about this data is that we were asking people about substance use that was connected to their work. So did they do it while at work or before work? When we looked at individual industries, we noticed that the risk of use changed depending on the industry. So for instance, we found that managers were more likely than workers to report consuming a substance if they worked in the construction industry or in the oil and gas industry. But there were also nuanced differences here. You can see that the use was almost double for construction, but with the oil and gas, it was much more, the difference wasn't too substantial. In contrast, we found that workers in forestry and mining were much more likely than managers to consume a substance, and the differences here were quite substantial. The key takeaway from this information is that industries differ. There's not a one-size-fits-all approach. So as an employer, it's going to be really important for them to figure out what their needs are in their context in order to have an effective ability to address the impact of substance use. So stigma, we've been hearing about already. Stigma and discrimination against people who use substances are obviously can be a significant barrier for them to seeking help. And from what we heard from the people we talked to, stigma and discrimination occur quite strongly in many workplaces for people. So when, in our study, the majority of people who reported using a substance before or during work said that they hid their use. As many as 6 in 10 people would hide their use. About half of the people gave another reason for not being able to work, such as being sick, but this is still hiding their use, so a substantial number. Only about 4 in 10 people actually disclosed that they were using a substance for the reasons that they could not work, so a much lower number. So we heard a lot about we heard about a number of reasons that contributed to risk for substance use in workplaces. These aren't all of them. There's a list that we're compiling, but some of the ones included that substances were used as a form of celebration. There were gender differences or sex and gender differences in some of the places that we talked to. Sometimes it was the work environment. Were they isolated? Were they working shift work? We also heard about a culture of toughness and also a culture of wanting to do it all. So there are a number of different factors, and they can differ depending on the industry you're in. However, there was one risk factor that came up repeatedly in most of the things and most of the people that we spoke with, and this was workplace culture. So workplace culture refers to the norms within an organization, its expectations and practices that influence the employee behavior. Now, in this graph, you can see that the acceptance of alcohol and cannabis differed depending on the industry. Some it was stronger, some it was less pronounced. But what this does tell us is that workplace culture really is a major contributing factor to whether or not somebody is going to be using a substance. We also looked at peer pressure. The data isn't up here, but just to know that culture does matter in someone's substance use. In terms of policies, between half and 3/4 of managers reported having some form of policy on substance use. Employees were a little bit less aware of their policies. And I just want to clarify that we didn't qualify the quality of the policy. For some people, they could have been reporting about a 2-sentence policy, something that says just don't use substances, up to people who might have had a fully comprehensive policy. In terms of training, between 40% and 60% of managers, they reported that they do not think that they've been adequately trained to manage a substance use issue if it occurs in their workplace. So we've heard from many that they would like some training, and they really want to help, but they're just not quite sure how to do it. So just finish off with some of the key recommendations from our study. First of all, is for employers to have clear and comprehensive policies. Really good thing to start off with is a needs-based assessment. Check out what your particular industry needs or your particular organization needs. And they do have to be clear and specific. People need to know exactly what their parameters are for substance use. Another thing that we heard, obviously, I just talked about trained managers. In this case, we need to be training our managers, and CCSA and other organizations can help you out with those pieces. Trusted individuals for disclosing, this is really important. A manager isn't always the person somebody feels comfortable disclosing to, so make sure your organization has some alternatives that they can talk to. Workplace culture, also important, as I mentioned. This is a place where get an outside needs assessment. They can talk about what the culture is, and we've talked to some organizations who've made this shift They made the efforts to change the culture in their organization. It was really impactful. Everything from just changing what they celebrate with. It didn't have to be focused on alcohol or other types of substances. They changed them to new ways of celebrating. You can change your shift work. You can change, there are different ways to change risks into protective factors. Build the protective factors up, so once you know what your risks are, these can often be transformed into a protective factor. And lastly, offer appropriate supports. Not all organizations can afford supports, so there are free ones out there, but what's really important is just making sure your employees know that there's a place to go, even if it's just compiling a list of some relevant supports that they can use. So I'd just like to finish off with if you'd like more information, we're happy to provide guidance, resources, and training. But I'd like to just finish off with the person I quoted at the beginning of the presentation. He now is working for what we would call probably more of a model organization that's affecting substance use. He works in an organization where they have peer support programs, they have a policy on substance use, they have regular check-ins, and they do a number of different things to help support his activity. But probably one of the most important things is they hired him knowing he had a substance use disorder. And they were willing to work with him to make sure he had a successful work environment. So it's really quite possible, and it's just something that I think we can all aspire to. Thank you.
Excellent. Thanks so much. And I think given although we're providers or researchers, clinical folks, or from various paths here, one thing is we're all in a workplace of some kind or organization. So as much as this is about the people we work with, I think it often hits home for us as well. All right, now we are going to hear from Miguel, who's going to talk to us about substance use health competencies for all prescribers. Miguel is a senior knowledge broker, passionate about equity and leadership in the context of substance use health. Prior to joining CCSA, Miguel worked in healthcare leadership, public health harm reduction, critical care, and crisis relief in Thunder Bay. Miguel holds a Bachelor of Science in Nursing from Lakehead University and a Master's in Public Health from Memorial University. And I think, Miguel, you've done this presentation with one of your colleagues, Sheena, and Sheena Taha is in our audience over here, and Sheena is one of our Associate Directors at CCSA. And over to you, Miguel.
Sorry, Sheena, that was really rude to just point. I just got really excited.
Well, I wasn't.
So thank you so much. Okay, sorry, first time with the pointer. All right, how's everyone doing? There we go. We're awake. Okay, so I have no conflict of interest to disclose at this time, but I have nothing but immense gratitude to be here with you and to share my enthusiasm, and hopefully I can get some of that energy back from you by the end of our time together. And you know what, no pressure. It's okay if you don't, but I'd love it if you did. So, all right, let's get my nerves under control here. What I'm here to talk to you a little bit about is some work that we were entrusted to do, as some of the folks of you who are in the room today may have been involved with, and I'm really sorry if I'm taking you back to that difficult time in January 2023, where the Government of Canada embarked on this really intense journey to explore the development of national standards for mental health and substance use. If you weren't part of that, I'm sure most of the folks in this room can appreciate that that's a pretty big job. And one of the aspects of that work was to support the workforce development to rise to this occasion. For those of you who don't know, let's see if it works. Yes. Oh, okay, well, you missed all the graphics, but this is a very fancy graphic slide for you, which is more than fine that it's not there. But for those of you who don't know, CCSA has been in the game of competency development, workforce development for quite some time, since 2004. Within that time frame, we've developed technical and behavioral competencies for the substance use health workforce, which includes both regulated and unregulated professions. And so because of our legacy and because of our reach across Canada, so this is my fancy map for you to show about all the areas we've been implemented across Canada, we accepted the challenge to develop competencies for all prescribers around substance use health. And this document, or this guidance document, was grounded in 3 objectives. And one of it being, I think we're all quite aware that access to care, particularly substance use healthcare, is a challenge. I know I have some colleagues here from Thunder Bay, but we know that depending on where you are in your location, place, and even with some of the intersections that you hold, access to care is difficult at the best of times, never mind if you're looking for support with substance use health concerns. So our hope for this document was to actually provide language for the ground floor for providers outside of specialty medicine. So actually primary care, acute care, I don't need to list it, I'm talking to the right audience that understands that term. But to kind of, sort of to Anthony's earlier point, is to be able to see substance use health as part of health in our discussion, or sort of in our approach and our practice, but also to give language to folks who are accessing those services to have a reasonable expectation of what to get from that interaction as well, that are rooted in principles around humanization, anti-stigma, and anti-racism. Our long-term vision for this work is that it actually creates predictability, consistency, and standardization around the care related to substance use health. So when we say that, I'm not necessarily speaking about specialty. I'm speaking about that it is encompassed in baseline care. So we didn't just go about this willy-nilly. This was a part of the Standard Council of Canada process for a publicly available specification. So it has, for those of you who are familiar, it does have a quite rigorous process from a standard development, but a PASS is a sort of rapid standard development process. I like to call it like the double cheddar, the junior chicken to the Big Mac. It's not quite the big dance, but it has the capacity to get there. We like it. It's good. It's a good amuse-bouche, but it's not the whole meal. So, thanks for laughing. And so our approach mirrored that. We followed the PASS process. Our literature review was focused on best practice guidelines, trying to summarize that at the national level, which was quite a challenge because obviously regulation varies province to province, and so you'll see that reflected in the technical competencies. We worked alongside incredible technical experts to make sure that our work was validated, and this included blended expertise. When I say that, I mean folks that have sort of that two-eyed seeing, but also lived and living experience and an intimate understanding of both sides of that experience, of both caregiving and being cared for, ideally. The PASS process also has a consensus building component. So this part is definitely mirroring the components of a standard development with a steering group, which consisted of champions and leaders, thought leaders, organization or regulation leaders around healthcare, particularly around prescribing. And then the review panel, interestingly, is actually the folks who aren't directly affected or directly responsible for implementing the PASS, but they would be directly affected by the implementation. So those folks were specifically recruited and invited to comment on the document, as well as the public, the general public. So this document has actually been through a public review over a 4-week period, and then the final draft, which again went through our quality checks with our steering group, our technical experts, which included blended expertise, and our steering group. So into the good stuff. Still with me? Woo! I got a woo. I'll take it. Thank you. So the document is divided into our classic way of presenting this work, which is technical and behavioral competencies. What's unique about a PASS, however, is that it's going to look a little bit different than our original documents in that we like to highlight a practice opportunity, but in more clinical terms, it's the rationale for why this should matter to you as a clinician, why this should matter to you in your practice. But it's interestingly principle-based. So I will preface that none of these things are necessarily overly prescriptive. They're a little bit aspirational to a certain extent, and we hope to be able to iron out those pieces as we work on the implementation. This is step 1, phase 1 of the document, and so it is really principle-driven. But it's also really important that it's principle-driven because there's some really interesting pieces in the behavioral competency piece that I'm racing to get to because it's my favorite part. I'm going, Anthony. Don't pressure me. So out of the technical competencies, I think I'm speaking to a room of folks that can probably get behind and co-sign much of what you see here. There isn't anything inherently problematic about the list of competencies. Keeping in mind that the audience, the actual implementers of this work, are your colleagues who, if there's folks who work in RAM, they're your colleagues in primary care who are you hoping to kind of be able to offer this document as like, hey, I'm ready to discharge. Here are the skills. Are you comfortable with these skills? Here's this document. Bada boom, bada bing. Not that easy, but you get me. The way that this is all outlined is exactly the way I prefaced, in that there's opportunities, principles, and indicators. And I know that, again, speaking to this group, there isn't anything super novel in the information that you're going to see, particularly in the technical competencies. But it's important that it's said, and it kind of backs up what Anthony talked about earlier. It's normalizing how we talk about substance use health. And when we do that, we actually see that it's quite accessible in terms of, and I'm not talking about the 4% that's living with disordered use. I'm talking about the 72% that have normalized use across the spectrum and across different substances. And sometimes for various reasons, which is probably a separate TED Talk in and of itself, we can kind of get in our own way to be able to see that it is accessible. And so we hope that the language, particularly when the technical competencies, disarms a little bit of that discomfort and also level sets and normalizes substance use health in the context of non-specialty settings. There's I should have said the previous one, which was understanding competencies, is a more theoretical technical competency, and this one obviously is very practical, clinical, prescribing-based technical competency. What I wanted to note here is that we shied away from actually providing specific dosing in those pieces, and you'll see in the document that if you wanted to dig into that, that we offer national level guidance, and obviously that you're going to have to adjust for your provincial regulations and constraints. Okay, 5 minutes, buckle up. I'm just kidding. Okay, thank you, so generous. I really racked my brain a lot before coming here to talk about this part, because I couldn't imagine a better time to have this conversation around behavioral competencies, to be frank. Sometimes when we talk about just how to show up in our work, we can get really lost in some of these sort of virtue signaling conversations. And I think in healthcare so much we water down those pieces, and also we forget how difficult it is when we're having an intense client load, and we can sometimes lose sight that like small gestures can make the world of a difference. It's not, to quote some of my young athletes that I coach, it's not that deep, but it is. The work here that you see, these are the behavioral competencies. It took a long time actually to distill it down to 3. But these 3 are so important, and it's not to say that this isn't already happening in the work that you do. And this applies to anyone in this room, whether you practice addiction medicine or don't, whether you even practice clinical practice at all. And I won't spend too much time getting into it. I think actually my main message today is actually a little bit of a call to action and a grounding of this work. What you see, or what you will see, and I really hope that you do spend some time reading through this document, is that this is a summary of voices, many, like hundreds of voices of people that you've likely seen and have sat across from you. These competencies are their vision and hope, despite all the things that have happened in their lives, to not have hope. But this is their hope, that someone will hear that these are the values, principles, and just simply being of how we hope that people in the position of prescribing and caring and receiving can show up. And so I really invite that regardless of where you are in your practice, to honor that wisdom that's distilled here, that we did our best to distill here, and I hope that we did a good enough job. But it is a call to reflect on some of those pieces, because this isn't, like I said, I can't think of a better time for us to just take stock. And these things aren't very far away from, if you're a nurse or a physician or an NP, they aren't that far from what we're held accountable to. So humanizing substance use healthcare is about about just that. It's about recognizing the person across the room. It's being able to make eye contact and sit with the narrative that's there. It's honoring the narrative in conjunction to the empirical evidence and balancing those two. And it takes time to finesse. A lot of the presentation of these behavioral competencies were rooted in principles related to anti-oppression and anti-racism, and those are big, scary words sometimes. But we can show up in ways that challenge power or that acknowledge power, that support agency, and that elevate autonomy. And sometimes that's more than enough. And so you'll see that language weaved throughout the document and throughout those behavioral competencies. So, thank you so much for letting me nerd out, and I look forward to having more conversations with you today about what this looks like in practice and how we can support you. Thank you.
Thank you. Can you flip there? My bad. There was a pointer, there isn't a pointer. Excellent, okay. Well, we've got lots of time for discussion as promised, and thanks to our presenters for sharing this information. We want to make sure that we can, answer questions. I see people scribbling, so please, I think there's little sheets of paper still at everyone's tables. You can scribble away, or if you'd like to ask a question, I don't know if there's a mic or if people are just going to be, yes. There is. No. I'm not sure. Okay, good. We've got mics. Yeah, no problem. It's just that it's hard to hear. We'll start 1 and 2, and then we've got papers, and Dave's now has to figure out how to run, how to do mics, how to hand things to me, and I have to not fall off the stage. Okay, go ahead.
Hi. I'm an addiction psychiatrist. I work in private addiction care. And this talk resonates with me because regularly I see people who come to treatment because their use interferes with their work, but they don't think of themselves as sick or needing hospitalization, but they can't handle the process of moving from heavy use to not using anymore on their own. So they need kind of a space, like a live-in treatment facility. Mm-hmm. But if they sit down and talk to me, I'm conscious about how much they don't want to be identified as ill or sick, etc. So the stories range from people who lose employment because of use, they get caught using on the job, and so they lose their job. Mm-hmm. And on the other end of the spectrum, there are people whose bosses are paying for them $1,000 a day to be in treatment for their substance use. I mean, this seems like a problem of equity, right? Mm-hmm. So can you, have you any data about that? I see quite often employers who put up the cost or pay for their employees to get treatment. So how do we get more of that for people? It seems like a really good idea. But do you have data about that, and do you have ways of communicating to employers to actually go that way, not just like messaging? Because these are clients who would never go to a hospital for care.
Okay, thanks. Shauna, or Anthony, who would like to start?
You can start all back clean up.
Is it okay?
Okay, yeah, we're good.
I personally, we haven't collected data on what you're asking, but we heard a lot about it in the conversations that we had with people. And there's no doubt that the addressing substance use at an employment level in the workplace widely varies. Some employers have told us they want to help, but they don't actually have the funding to do so. So part of it is communicating to them that there are free resources, there are resources that don't cost as much money. However, having said that, there's also wait lists for a lot of these things too, and so it's a bit of a challenge. On the other end of the spectrum, we have I've had HR managers actually walk up to me and say, you know, we have this problem, but our leadership doesn't want to address it or doesn't want to acknowledge it because they don't want to be seen as a business that has a substance use issue in their organization. So the messaging for them is usually, you know, that starts at the workplace culture level, that starts at the leadership level of like, we need to be talking about these things from a stigma and what the impact it has. And I think this is a really good place where CAPSA comes in with the substance use health model by changing that conversation. It doesn't have to be about, it's just a misnomer, like people don't necessarily understand what substance use means, and that for somebody on the extreme end of things, it's from a medical perspective, it's something that's maybe without of their control, but on the people on the other end of the spectrum, they're not recognizing that they're in that situation. And so the barrier I often experience is just employers, there's a real knowledge piece that needs to come in there. There's a real educational piece that needs to come in there to talking about what this is, but also empowering employers and showing them how they can manage this. A lot want to, they just don't know what to do.
Yeah, well, it's still early days for us to actually collect data. We've implemented a workplace assessment, a healthy workplace assessment, where organizations can assess their level of stigma and look at their policies to see how supportive an environment the workplace is in terms of people's substance use health. But to date, I would say that a majority of the organizations that we've engaged with have a fit for use policy or a fit for duty policy. Thank you. Fit for duty policy, but not a substance use health policy. There's nothing in their policies that describe a situation where you've identified an employee that requires support around their substance use health, and what is the compassionate and non-stigmatizing way that you deal with that situation. So it does really boil down to culture. And sadly, in most workplaces, that substance use in the workplace is treated as a performance issue, not a health issue. So the employer focuses on job performance and penalizes people for their job performance without uncovering the underlying health issue. So in talking about substance use health, even sitting down at your new employee orientation and you're presented your benefits package, they'll tell you how many times you can get your teeth scraped a year. They'll tell you how many times you can get a massage, right? They'll tell you we have some drug coverage, but no one tells you that there's residential treatment coverage available in your policy, right? So when I needed help and reached out to my insurer, because I didn't know if residential treatment would be covered, I reached out to my insurer. They didn't know. It took 3 days for them to get back to me saying, yes, we'll cover your residential treatment. And so let's just recognize the privilege in that conversation as well, because I had insurance coverage that got me a bed immediately. There's plenty of people in workplaces that don't have that privilege, that have to wait for public beds. So again, that discussion of health in the workplace is so important so that people can talk about their substance use health and have options when we celebrate, when we gather as employees, where it's not always focused around alcohol and substance use. Anyway, I'll stop there. I think I've made my point.
Thanks. We'll take the other question from the audience, and I know I've got some people applauding here under the table, so that's great. Go ahead, sir.
Hi, I'm a physician here in Ontario, and most of my workplace treatment experience is around nurses with substance use problems and under monitoring contracts with either the College of Nurses of Ontario or the Nurses Health Program. And the thing that I hadn't heard mentioned around workplace and stigma is that I've had a number of nurses who are in healthy, stable recovery. I see them weekly. Their urine tests are pristine. They're very capable people, and workplaces will actively and I think illegally discriminate against hiring them on the basis of health condition, deny that they've done so, and some of these people can't get a sniff So one in particular works at a very large, well-known hospital in Southern Ontario, or worked for 20 years. One of her references was the former director of nursing of the entire hospital. She had an alcohol use problem that came out after some personal tragedies. Ended up working in a nursing home for about half the pay. Put out 400 resumes to that hospital. Did not get a single interview. Even actually got an interview at Homewood in Guelph, and when they found out she was in recovery and 3 or 4 years sober, they said, the position is no longer available, and then the next day it was back up as available. So what can we do about workplaces who do this, if anything? Because it's actually kind of made me question some of my life choices also personally. It's like, why am I working this hard with my patients to help them get this healthy? I mean, there's obviously benefits to them being healthy. When they can't get back in, and finally, and I'll shut up in a second, I saw studies published in the American Family Physician that said that maybe up to 10 or 20% of nurses in the States will have a trouble with substance, whether it actually reaches severe substance use disorder or not. It doesn't in all cases, right? Mm-hmm. So these people are actually healthier than maybe 10 or 20% of their workforce that's currently there, because we know this person's sober because they're so rigorously monitored. So what are you going to do about that?
Yeah, and
thanks for listening.
Yeah, thank you. And thank you for the work you do, well, for the work everyone does. But in terms of the stats in Canada related to alcohol use in the workplace and nurses, just because I do some of this work at the hospital I'm at as well, and we actually have a workplace health program that includes substance use health for our healthcare workers, and it's about a 40% increase in alcohol use health concerns amongst nurses here in Canada since COVID, so over the last few years. So this is a massive problem that we have, and we already have an HHR, health and human resource shortage in our healthcare centers. We can't find a nurse. Sorry, Miguel, we can't find a nurse. I know, can't find a nurse to work with us, and yet we have people who have, and you know, whether the word's recovery or wellness, and they're in a space where they can contribute, and there's some systematic discrimination that prevents them from engaging in their craft and supporting the wellness, and maybe even being super understanding of other people who have these similar struggles in our day-to-day work. But I'll turn to you, Anthony, to start, just because I know you'll have 1,000 things to say.
Oh, so many thoughts. A little bit of history. White people voted in favor of allowing black people to vote. Men voted in favor of giving women the right to vote. It's about allies. It's about allyship. Do not rely on the nurses that are being discriminated against to put their hand up and say this is wrong. It's up to their colleagues to say that the treatment of these people is incorrect. Something needs to be done. And to say that these are capable people, I work with a team that is incredibly capable. Our substance use disorder does not define us. When we're in the midst of it, and when we find some wellness around it, it does not define us. And it is necessary for allies to come alongside, not to come in front, but it's necessary for allies to come alongside and support us in finding the equity that we deserve in that situation. And I was in treatment with lots of people in the medical profession. And the fear in losing licenses and the fear of continuous monitoring is palpable. You're physicians, you know what cortisol does to a body. When you're under chronic stress because of a life that you once led or continue to lead, when you're under chronic stress, that cortisol does a lot of things, not just to your brain, but to your body. Plaquing arteries, building body fat, all that stuff. And we need to start turning down the temperature on that stress and allowing people to function in a profession that's helped so many of us.
It was very well said. Thank you, Anthony. I was just going to offer a couple of options or potential considerations. One of the things to consider is, and we face this with many people we talk to, is that when there's regulatory bodies, unions, contractors, and employers, there's often multiple different policies, so it gets really convoluted for, I think, anyone trying to navigate that system. So I'm guessing that your nurses, because we heard something similar from those in BC, actually nurses practitioners in BC who said they were facing a similar issue. How do they manage between the different bodies they report to? One thing we did hear, we heard of a success story in BC, actually, one individual who is a nurse, and in his capacity, they worked with him, his employer worked with their regulatory body and their union to find a path forward. They got together and they all talked about a solution. And one of the things they use, and I'm guessing it may come up in your work, is return to work agreements, where they work together on an agreement. What's this going to look like? What's the possibility of, having a reoccurrence of a substance use issue? And they put out a plan together for about the next 1 to 2 years about what this is going to look like for this person to come back to work. So those are a couple options. There are some organizations out there who do it. We just need to tap into those ones who are doing really well with it and use them as kind of models to work to go forward.
Many hospitals have those already. Many hospitals have those already. It's the ones that aren't familiar with that don't, and aren't even hiring these people.
Yeah.
Right? That's the issue.
There's an awareness level. There's some education for sure.
It's not going to answer your challenge in the immediate, but that's what some of the competency work that we've done that peels out the principles that I talked about in the end. Is twofold: is working with organizations, hospitals, all kinds, to adopt these competencies, which are inclusive of those behavioral principles, so that there is a bit more humanism in those policies. Because it forces that standard, and then leadership is also forced to align with those pieces, and it kind of has that trickle-down effect. So that's some of the ambition behind that work. But then also, too, for the individuals, what I failed to mention is that the success of technical competencies are underpinned by the behavioral. And so clinicians and decision makers in the situations that you see yourselves in and that are in charge of enforcing these policies, those things can't go in exclusion of each other. So I appreciate you raising the concern, because it's quite palpable.
And I think what we're hearing, and as Anthony so well said, is, what's our role here on how do we help instigate this change? So folks like what you're talking about are continue to support the work that you do, the important work, and our colleagues who we work alongside for all those years, and we need to come back to do their work, because, well, there's not enough people to do the work. And second of all, our work is to help people be well and stay well. So I kind of think it's maybe what those of us in the room are going to do to help support that. So thank you. I know there was, did you have something else to add? And I know there was a comment in the back too that I want to pick up on. Yeah, I see you there.
I was just going to say that I work for Canadian Addiction Treatment Center, and there is a culture of pride in hiring nurses and care professionals with lived experience. So she might want to seek out those places.
I have provided that advice to all of those nurses, and sometimes the hiring person is in recovery, or their sister or someone's in recovery, but that's like winning the lottery. It's like 1 in 100, but thank you for that. That's a great reminder.
Thanks. I think there was, would you mind running the microphone? Thank you. We've got lots going on. Then I got to get to the questions up here and then back to the audience. Go ahead.
So just a comment on that. I've actually seen some nurses that have done return to works where they've had substance uses and they're coming back, and more often than not, they're not allowed to do certain duties that flag them to the other nurses and other staff members that they actually do have this concern. And so it actually causes them to want to hide, or not even to want to go back to an organization that they feel more comfortable with, or that they know they can get their job back. So we need to maybe start doing different policies that makes it so they can still do their duties, like provide narcotics, provide this, provide that, where it's monitored, but not essentially being shown to the rest of the nurses that they're not allowed to do this. I'm a nurse myself, that's why I've seen it multiple times. And it's not fun to see that because they stop talking with other nurses and they isolate themselves, which actually puts them back into wanting to use.
Thanks. Any comments on that? Or I think that was a supportive comment of this work. Great. Are you okay, sir? Oh, okay, great. Thank you so much. Okay, thanks. All right. We've got workplace questions and we've got some other questions, but I want to also switch set because Miguel, you tied that competency discussion to this, and we have a few things. So first of all, you got lots of thank you for your enthusiasm and being wonderful. That's summing up. And people really appreciated, not surprising, maybe it's the way you presented it, Miguel, the behavioral competencies. So some of these questions about this, and one is, the person who wrote this, noted Saskatchewan is not represented on your map of areas for competency development across the country. Given the high prevalence of harms due to substance use and opioids, what's happening?
I don't know how to put stuff on a map.
Okay, so we don't.
So we are in Alberta.
But not Saskatchewan.
Right? Where's Saskatchewan? There we go.
Okay, so
I know you can hate on me. That's fine. I'm like at least humble enough to recognize I don't. I'm like, where is this?
Alberta and Saskatchewan would be between Alberta and Manitoba.
Thank you.
Yeah,
Thank you.
no problem.
Thank you. We're in Alberta, so it's adjacent. Yeah, not Saskatchewan, oddly enough, but we have worked with the university around competencies, so that's actually genuinely my error. Like, we worked with the university way back in terms of the development of competencies. In terms of the implementation of the PASS, not so much. But we have worked in other competency work for sure. Yeah, sorry, in academia. And as you can see, geographically, not my forte. But we are there. My apologies.
That's okay, Miguel. I sometimes have a hard time finding back to the hotel, so it's
hey,
okay.
No, that's fine.
So I think with that, though, if folks had questions how they can get more in Saskatchewan, can they reach to you?
Absolutely, yeah. So if this is, like I said, we were very limited to one contact historically, but since then it's been quite slow. So if there are folks here that would love to connect, please do. And now I will never forget where it is. Thank you.
Learnings all around.
Public embarrassment does a really great job of ingraining it. You're so kind. Thank you.
Sharing other embarrassing stories. We can all go on and share it. Go ahead, Dave. Do you want to bring it to someone else, or is it you? I got a question.
It's just to try to kind of guide this discussion. It's stirred a lot of passion, and there are many people who want to continue this thread. And I wonder if we should, just because I don't know, I haven't been keeping track of the time properly to know how much time you have.
We have 20 minutes.
Okay, I've encouraged people as well to write their questions to ensure that they're not lost or forgotten, but with your permission, I'd like to kind of let people process their emotions. And I'll preface passing the mic along with, this body of work too seems like it's a wonderful opportunity for a collaboration with this organization. And I'm hoping that we make inroads to making that sort of thing happen. Like, this work is something we're all passionate about here. Are we okay to continue the...
Yeah, and I'm sorry if you saw me get emotional about this, because this is the work I do and the people I see and the colleagues I work with and hearing these stories. So yeah, no, this is very emotional, and we can go back, and I think as long as folks are comfortable, if folks aren't comfortable, we can try another way. But thank you, Dave, for helping me manage from the ground.
Yeah, I've got my finger on the pulse of the
Okay, I'm blinded literally by the light.
It was my question. I work out of University of Saskatchewan for chronic pain and opioid use disorder. Okay. And I have chosen Saskatchewan as my place of work. My family lives in Ontario, and I've done some work in Ontario, but I've chosen Saskatchewan. Unfortunately, Saskatchewan doesn't represent itself nationally well, and it really hurts me because there is a lot of substance use. There's some work that we are doing. We are all trying to do some work in our own way to contribute to wellness and substance use health in our practices. But maybe we don't do a good job of research. And I know just yesterday I was at a seminar where we are talking about CSAM and how to get our data on a national repository as well, so that we are heard. We do have the notorious distinction of leading the country in opioid-related harms and deaths. So we do have a lot of this work that we still have to do. I think we have to see how we join hands with our national partners. And
Yeah.
thank you.
No, thank you so much, and I welcome that for sure. Are you talking specifically about the past? I also just don't want to umbrella.
Yeah, that's specifically about the competencies.
Yeah,
that
okay,
you
wonderful.
presented.
Yeah, I think the document, one of the pieces that we were wrestling with when we were drafting the work is that we were really hoping that it would invite dialogue and conversation, not just with us and partners, but also like intercollegial conversation. This document can be a resource for folks who are in specialty, talking to colleagues who maybe they're close with and who they dialogue a lot with, that can be used as a really great starting ground. And specifically in contexts where, I mean, Saskatchewan is also, I might not know where it is on a map perfectly right now in this moment because I'm very nervous, but I also understand that specific context and that there's a lot of intersectionality, but that rural sort of isolation component of Saskatchewan has a lot more nuance from the social and systemic pieces that I spoke about. So I would love to talk a lot more about that. So please, yeah, let's work together.
Thank you. And I'm pleased to see this real-time networking happening in the room with people reaching out to help each other. Like, talk about, impact here. So Dave, did you have someone else that was in the, okay, sorry, I'm blocked with this part with the light, so please go ahead. I'm sorry I didn't see you there.
Okay, before I come to what I really wanted to talk about, I just say that of the provinces, Saskatchewan is the one that's hardest to spell and easiest to draw. It's the one with just straight lines in the middle.
It's also one that you can see your dog run away for days. Yes.
And I might also comment with Dr. Marwa, we have the highest HIV rate of any province, but our HIV is different. It's injection drug use and in young sexually active people. Now, the question policy was talked about with respect to safe disclosure, and that should be somebody who's not the manager, which I think is terrific. I would hope that you consider that your policy should also include encouraging disclosure from the spouse or partner of the person who may be at work. That's the person who may recognize a problem before the person who actually has it either recognizes it or will admit it. So would you consider in policy that one should broaden the access to disclosure?
That's an interesting point, actually. I'm glad you raised it up. I haven't had that suggestion before, so I'd have to look into it. I have to also be cognizant. So I'm not a lawyer, and I can't comment on the legal aspects related to disclosure. As far as I know, it has to come from the individual or a medical authority. I'll take your suggestion back and kind of find out more about it and see what there is to that. Just recognizing that I can't provide like a legal response.
I'll just comment that within medical associations, I'm a doctor in Saskatchewan, and what's done for support programs is somebody totally separate from the regulatory authorities and stuff like that, but they encourage and get much of their input from the spouse or partner of the doctor will think they've held it together and not recognize or admit a problem. It's someone else who recognizes it and can bring people to help when they need it.
Thank you.
I was just going to add one thing. It's interesting that you bring that up. We did hear from people about a no snitching culture. So we have people who were uncomfortable talking about their colleagues. So there is something going on there that we have to investigate more and provide more guidance on for employees.
I can actually speak to that. I'm a pharmacist and I practice on the East Coast, and I work with employers to help them manage substance use. Most of the time I get called when there is a problem and the employer doesn't know what to do. So with regard to disclosure, to your point about policy, it's really important to have a component that identifies voluntary disclosure and that the employee will not be disciplined if they come forward. And to help with what you're identifying is you can also have coworkers, and I spend a lot of time educating about prevention and the outcomes of substance use, and that it's not ratting people out, which is the term I hear all the time. if you really care about your colleagues, you could be saving their lives. And then I go on to explain why. And so I begin to see attitudes change, but it's what you said, it's about culture change. So with that policy, not only is it colleagues that can come forward, but family members, et cetera, so that you make it as easy as possible, because those are the people who are most affected and will be most often the people who start the ball rolling in making that happen. But you have to have everybody engaged. The policy has to be very clearly written, and the employer has to be on board with it. So it's a lot of education, and it doesn't happen overnight, but I've had some successes that have been very, very rewarding with that.
Thank you, and I'm guessing Anthony wants to, there you go.
So if I may add, in the workplace, the individual with the substance use disorder is usually the last person to know. Trust me, all your coworkers know. So it's not a matter of snitching, it's a matter of willfully ignoring the issue. So this is what we talk about in creating a culture where substance use health is discussed just like physical health and mental health. And creating a culture where the individual that requires support for their substance use health can step forward and say, I need help, even before they reach the disordered level. But trust me, everyone else knows.
Thanks. And I think this is going to blend really well to the next question, because it kind of, all this is fitting together with these behavioral competencies around humility and compassion and non-judgment. And I think humanity was actually the first one, if I recall, humanness, right? And it's interesting, someone wants to know, so how do you know someone achieves these behaviors, right? Because I'm thinking you can measure how many, the way people write their prescription or their dosing, but how do you ascertain whether a clinician has attained the competency of humility? And can you actually train it?
Such an amazing question. And thank you for whoever offered that challenge of reflection. So when I've been reflecting and when the team has been reflecting on these pieces, I think we've kind of fallen into the trap of sort of Western ways of evaluating success. It's a checkbox indicator that I've reached this point, but so much of the behavioral indicators is about building relational competence. And that cannot be evaluated in isolation. That is not a I think, oh wow, I was told to be quiet. That is not something that can be done in a self-evaluation. So in the absence of providing you, and I hope we can get to this place where we can blend Western ways of doing things in terms of evaluating and giving you something tangible to walk away with, because I think there's a lot of value in that. The way I can answer you today is that it's done in partnership with the person in front of you. Did they show up again? Did they disclose, did you share vulnerability? I think those are the things, it's the relational quality, and you know that. You know when someone's beginning to trust you. It takes, but the other piece is that it takes time. It's not a one-off, it's a repetition of the expression of those competencies that come over time. And so I recognize I'm not fully answering you necessarily, whoever the wonderful you is. But I do think to be a bit more direct, it is done through relationship, and it's not something that can be just self-evaluated. It's something that's done in partnership with the individual, asking daring questions like, is what I'm doing actually helping? Is what I'm saying landing? And then can you train it? And I do, you can. I think you absolutely can. I think there's wonderful people in this room who have dedicated a lot of their time and effort at CAPSA in terms of having supporting resources and training around compassionate care. So I do think it's a muscle that we can build, and it's a muscle that we can flex. And it just, unfortunately, some of those things take time, and there are certain individuals that have the advantage of having a bit more intimacy with those experiences that lend themselves to developing them at different paces, but I don't think that should discourage any one of us from trying.
Can I add? Just as somebody who's taken this compassionate care training that we're talking about, I think as our groups of people get this types of training, or other folks who are in obviously I work at hospital, but in our workforces, it starts to become the discussions that we have, because we're all kind of held accountable to these same ways that we're trying to move our practice forward together. So it kind of gets ingrained in, not kind of, it actually does get ingrained in our discussions, the way we frame things, the way we work things, and we end up, Miguel, holding each other to that. Now, I don't know if everybody can be held to anything about everything, but I think it's a bit of a tipping point as well of what it becomes. So I totally agree. Okay, a couple more questions before we wrap up. So shifting a bit in terms of community alcohol-related risks and harms, is CCSA considering campaigns that address the social ritual acceptability of drinking? That is, it's actually socially encouraged legal substance. And we heard that from across the room here. People are talking about the stigma of what happens when you don't drink. I think that's, the socially encouraged use. So I think that's for you and Pam.
Yeah, I mean, I could start. I have seen some interesting campaigns. The World Health Organization Europe just recently did a Redefine Alcohol campaign, and that was meant to help people think from different perspectives about alcohol. So how does alcohol affect your parenting and your ability to show up as a parent? Someone as an artist stopping their alcohol use or backing off their alcohol use because they thought it was affecting their art. So I do think that there is a real room for this, connecting with people's ambitions and connecting with what people want to accomplish in their lives, as opposed to oftentimes it just sounds like do less of something you enjoy is what it sounds like. So I think that I would love to see our organization move in that direction. In terms of the social expectation to drink, it's a pretty big one it's a challenging thing to address, because I think it's hundreds of years ingrained into the culture that we live in, so that it's turning that around. You need to start carefully and start slowly and think about what's the conversation you're starting. Just because, again, I think it's the only substance that you raise a toast with at a wedding. It's the only substance that if I walked up to someone I knew and said, "Nice to see you, we should go have maybe a coffee, but maybe an alcoholic drink." So it is very embedded into the way that we celebrate and the way that we socialize. So it is a challenging thing to take apart. I'm behind too. I don't know if anybody else wanted to speak to that one. Yeah, please.
Just briefly, so I want to be very clear that we're not a temperance organization. We're very much about informed decision making. So I drive to work, listen to the radio, and in the morning they're talking about alcohol. And I heard that there was more vitamin C in a shot of whiskey than in an orange. So how is that responsible health, right? And we've been told for years that red wine is good for us, all those biophenols and all that, right? You can get the same from a blueberry, by the way. Hopefully local and organic. So yeah, there is a huge cultural issue here, but again, it's not going to change. Since man first crushed grapes, we have consumed alcohol. Yes, lately it has become very much the wine culture, the alcohol culture, but again, it's that providing information. Let's treat adults like adults. Give people information so they can make informed decisions. Let's just start there and see what happens.
I'll just, again, go back to the cost study, the CSAM project, and the graph I showed from 2007 to 2020 with the costs of alcohol rising. But the costs of tobacco have decreased by 20%. I think that shows what's possible, really. If we take really strong public health measures for alcohol, that we have done for tobacco, we can make a difference. That's at a population level, and you see it, and that is a steady decline. So I want to say cautiously optimistic.
So what does that look like then? What does that look like? So if we did it for tobacco, what are we supposed to do?
So, I mean, there's a good line of evidence around public health supporting, there's a good line of evidence around public health supporting alcohol policy. It's generally focused on advertising, availability, pricing, and taxation. Of course, treatments generally in that list. But the challenge is these are very unpopular. When you talk about raising the price of alcohol, when you talk about restricting, in Ontario, we just saw widely more available alcohol, hours of sale, you're talking about, it's a very unpopular, so cautiously optimistic that we can make a difference, but it isn't necessarily, alcohol is many things, including an economic product in society that many different kinds of organizations and people make direct profits from. So it's a challenging, I'm cautiously optimistic as well, but I think we need to just look at what's possible and what's realistic, and start where we can.
All right, I am going to read the last question. I think it's pretty amazing. We had 42 minutes of questions. We're like, oh, well, we ended on time. Maybe people will leave. So I think this says a lot to how important this work is to people in the room. So I think there's questions regarding, sorry, I'm going to try to read this well. So given the cost and the amount of crime related to substance use, do you have recommendations for persons in jail to focus on in terms of rehab, or what does this mean for corrections, I think is the question.
Well, I think it's certainly within the correctional, I'm wishing John Weeks was here to really answer this question. But it does speak to the need certainly for services and supports within the correctional services system. I mean, the survey, those attributable fractions that I showed were derived from survey data, and that intake survey does assess needs for substance use treatment services. So absolutely, I mean, within the correctional system, you have opportunity if you can provide treatment services for substance use. That can certainly help to decrease crime. The association is very strong. So,
and we are working with public, I think just in terms of the work that we're doing, CCSA, in terms of working with public safety and corrections around some of this messaging as well in terms of what it means, and not just for people who become incarcerated, but the big issue of when people
are released.
I guess the word's released. I say leave. Okay, I think we are going to wrap up. It is 3 o'clock. Thank you so much. An amazing thank you to our panelists, to those folks in the room. It's an emotional discussion. Please reach out if there's anything that I could do to help support you. And if there's any other questions, come on up. Otherwise, a round of applause for our panel and for those of you in the room who do the work.